Hello, my name is SBohanan, and I'm going to be presenting an oral case presentation on a 52-year-old Hispanic male who presented to the emergency department for reports of acute right upper quadrant pain that had onset 1 day prior to his coming to the emergency room. This patient's initials are going to be JR. He describes his pain as sharp, with no radiation, and that he's also reporting that he does have nausea and vomiting. He denies any kind of hematemesis. He denies any recent travel out of the country or any exposure to anybody else who's been sick. His review of symptoms tonight are going to be generally he denies fever, chills, or any recent weight loss. Cardiac, he denies any chest pain, cough, shortness of breath. GI, he does report right upper quadrant pain, onset 1 day ago. He is having some nausea and vomiting associated with this pain. He denies any diarrhea or any changes in bowel habits. In GU, he denies any dysuria, any hematuria, or any kind of flank pain. He does have a past medical history significant for osteoarthritis, depression, and restless leg syndrome. He also presented to the emergency room in July of 2025, also with reports of similar symptoms. During that visit, he was diagnosed with pancolitis, and he was told to follow up with a GI specialist at that time. He has had no prior surgeries. He denies any prior abdominal surgeries. He is not allergic to any medications. His current medication list is Celebrex, 100 milligrams twice daily for his osteoarthritis. He takes pregabalin, 100 milligrams at bedtime. He is on escitalopram, 20 milligrams daily, and he is also on trazodone, 150 milligrams at bedtime. Social history, he is a non-smoker, occasional alcohol use. He denies any illicit drug use. His family history is non-contributory. He denies anything that would be related to this. Objective symptoms, his vital signs are 98.7. He has a heart rate of 57. His blood pressure was 143/77. Respiratory rate's 18. He had O2 sat of 100%. Generally, he is alert, but he is in obvious acute distress related to his pain. His abdomen is soft. The bowel sounds are present to all quadrants. There is some tenderness that is localized to the right upper quadrant with mild guarding, no rebound, no palpable masses. His Murphy sign was negative, and he does not have any CBA tenderness. Cardiac, his heart sounds are regular. S1, S2 is present. There's no gallops or murmurs. Lung sounds are clear to all fields. He is GU. He has no CBA tenderness. Skin issues. He has no jaundice, no rash, no skin lesions. So while he was with us, so the diagnostic imaging that was performed and the labs that were performed while he was in the emergency room, so they did do an ultrasound. That was the first diagnostic test that was performed. That ultrasound showed no gallstones, no acute biliary obstructions, and there was no, but he did have mild left renal polyectasis. So, due to the fact that test was negative. They also did, while he was with us, they did do an EKG, which indicated normal sinus rhythm. They also did a chest x-ray, which was normal with no consolidation, no effusion, or no cardiomegaly. So labs that were done, he had a CBC. All results were normal except for he had a left neutrophil with left shift, 91.1%. The CMP, the electrolytes were normal. He did have a lipase, though. The abnormal was 240, with the normal values of 16 to 77. His urinalysis was negative. They did do a strep, a COVID, a flu. All of those were negative. His magnesium level was 1.40, normals are, which is low. Normals are 1.8 to 2.4. So the next diagnostic test that was performed when the ultrasound was negative, chest x-ray was negative, EKG showed normal sinus rhythm, was a CT of the pelvis with contrast of the abdomen and pelvis. So the results for that was no evidence of pancreatitis. Findings were consistent with colitis, bilateral non-obstructing renal calculi, and they also did notice a lesion on his right kidney. Based on those results, he was given a diagnosis of colitis as the primary with an ICD-10 of K52.9 and right upper quadrant pain, ICD-10 of R10.11. So differential diagnosis to consider with this. Kidney stones. He does have bilateral stones. However, they're non-obstructing, so they are not causing the patient any acute distress at this time. He does not have any hematuria, and he does not have any CVA tenderness. Pancreatitis, although this would also be a ruled out diagnosis due to the fact that he has a normal lipase, and he is absent of any epigastric pain. And then there's cholecystitis. Again, normal liver enzymes, Murphy's sign being negative, and he does not have any gallbladder pathology that was seen on ultrasound or CAT scan. So the plan for this patient will be, while he was with us, he did receive IV fluids. He received Zofran, 4 milligrams. He received IV infusion of magnesium for his low mag of 1.4. He did receive Oframev, 1,000 milligrams for pain. And then he was also again reiterated and stressed the importance of a GI consult for further evaluation and management. We also provided patient education, the importance of hydration, proper diet, making some dietary changes, bowel rest, and then of course follow up. Home prescriptions that were sent, he was given a Zofran, 4 milligrams sublingual Q8 hours, and Tylenol 300 milligrams, 315 milligrams Q4 hours as needed for pain. So the AAC and essential domains for this particular patient are 1.1, to demonstrate an understanding of the discipline of nursing's distinctive perspective, and when shared perspectives exist with other disciplines. So with this patient's repeat report of a similar condition, and so establishing that relationship, come to find out his wife is a nurse and was a nurse in this particular emergency room where she brought her husband. So that relationship is getting established with the patient of the need for and the importance of continued follow-up and establishing that relationship with the patient. The second domain is 4.1, advanced scholarship of nursing, especially to demonstrate an understanding of different approaches to the scholarly practice. So this is related to the fact that this is the second episode of right upper quadrant pain since July of 25. The various causes of the right upper quadrant pain being the stones, colitis, and his previous diagnosis of pancolitis, which is just like inflammation of the colon as a whole in itself, and just the lesion on the kidney. Now that was suggested by the radiologist to be followed up on for further diagnostics. And so just taking those different approaches and suggesting different methods of treatment, giving the patient the magnesium, giving the patient the offermed for pain control, and trying the different measures to figure out what's wrong with the patient, and that to determine the cause of this right upper quadrant pain. So thank you for your time.